this is going to be a no holds barred, uncensored, controversial as we want to be. Given everything I've talked about today, I am not concerned that we are going to have a fabulous conversation. I hope we are going to break some eggshell heads, because this is what you know, the 5 people who may not know you yet. What's it like to have a dual master's degree from including one from the venerable, and that's the only appropriate word I find for it, London School of Economics? How that plays into mobile medicine in an industry where there is apparently an equal controversy these days around whether to require an associate's degree at all, on the one hand, and on the other hand, whether it makes sense to stop there. And so you are an odd duck in some ways.
Okay, I'll take that too.
That's why I like it.
Yep.
But give me a sense of context. So, you know, but your background, how you got here, a little bit about the career, but your education. We're going to talk a lot today about education, and I think there's obvious political backdrops. There's the idiocracy reality that we're living in. There's going to be some substance use disorder. I hope we cover a range of topics, but you are one of the most thoughtful people I have talked to in this business, and you know it. So give me some sense of context.
Sure. So, you know, I like to think that, you know, my life has been a series of happy, well prepared for accidents. You know, I became a firefighter at 18. Not because I was planning on it. I didn't grow up wanting to be a firefighter. It was really at my high school, which was actually a predominantly white high school. I was the vice president of a club called Men of Color. The girls basketball coach, which I didn't play sports, was a Milwaukee firefighter. Asked me if I think about, you know, joining the fire department. They were looking to engage more people of color from the city. I told them no. And the more he explained it to me, the more I was kind of intrigued with it.
Why'd you say no?
You know, I wasn't in love with the stereotype, to be quite honest with you. You know, I wasn't a big, strong person. I wasn't, you know, a jock. I wasn't into sports. I was going to become an accountant. And not because I loved accounting. It was kind of because I was good at math, and I wasn't a great high school student. I really feel that I kind of defaulted to what can I do that I'm already good at, not really gives me great passion and joy. I had heard that moniker, you know, do what you love to do. I didn't have that love thing. And I'll be honest, a lot of people in my friend group didn't really have that thing either. I ended up, you know, applying for the fire department, got in, and I fell in love with firefighting when I was in the training academy. And it was really doing something difficult and having that peer support when I was in training was amazing to me. And I kind of, at that point in my life, I kind of unnerded. So I lost a bunch of weight. I got really strong in the academy. I'm like, you know, this ain't so bad. I went into the field in firefighting. At the time, I was just an EMT, which is a requirement on our fire department. You know, probably a year or so into my service, we actually resuscitated a 14-year-old boy who reminded me, you know, of me. His name was Derek. I'll never forget it. And in our department, our paramedics are all firefighters. So we have one of those dual departments where we do ALS transport. Fell in love with paramedicine. I'm like, I got to become a paramedic. Went back to school to become a paramedic. At this time, I was around 21-ish. It was the hardest thing I'd ever done in my life.
Why? I mean,
you know,
what about it?
Academically, it was so in the city at the time, we were doing it triple pace. So we would take you out of the firehouse, put you just in paramedic school 40 hours a week, and you were expected to absorb curriculum about 3 or 4 credits of curricula a week. Test, move on, test, move on, test, move on. And my brain wasn't, I had thought at the time my brain wasn't built for that. And like you can see the whiteboard behind me, that's how I got through paramedic school. It was rinse, repeat, write, draw pictures, erase, repeat, write, draw pictures, erase, repeat. And I realized that worked great for me. Became a paramedic, went through that for a while, realized once I was in the field that my patients didn't speak medical. You know, I was seeing, you know, a lot of diabetics who smiled and nodded at their doctors, really didn't understand, you know, how their disease would affect their life. A lot of asthmatics, a lot of people with allergic reactions, CHFers. So I saw all this chronic disease, especially in the African-American community, because Milwaukee is hyper-segregated. And I just wasn't seeing the level of understanding in the patient population that I realized that providers thought were there. You know, having worked in the clinical setting, having worked in the ED, having been a student, and having been taught, I realized that that wasn't trickling down. That fueled my love for community relations and community education.
By the way, you're about 21, 22 at the time?
Yep, I'm about 20. Yep, about 21, 22.
Okay.
Started really getting involved in community relations, getting involved in recruiting. I love that, and I said, hey, you know, we've done all this work around fire education and fire prevention, and me being, you know, probably more numerate than most people around me, I said the lived experience of somebody who spent 2 years at an incredibly busy company, our prevention efforts are so misplaced. You know, we're not, you know, and we had dumped a ton of time and money into fire prevention, especially in the adolescent age group. We're not seeing the fire deaths that we're seeing. I'm seeing deaths, you know, from diabetics, from people with chronic disease processes, from our older residents who have had disease processes for years, and all those comorbidities have piled up on top of them.
Sure.
And especially just seeing like the propensity of obesity, knowing how strong of a comorbidity that is, and just seeing how prevalent that was. I'm like, you know, our time is better spent and better resulted doing more in medical prevention than in fire prevention.
Okay.
So,
and this is before, I presume, the statistics around the 75 to 80% medical calls are being published. So you're seeing this through your own observation of the lived experience, as you put it.
Right. Yeah. This is all this. I mean, and granted, you know, it was there, but we weren't really talking about it. The fire service was still, you know, run in, break down doors, you know, kid over one shoulder, dog under the other arm, you know, blaze of glory in the background. And that's just not,
basically.
Right. But that's just not my lived experience, you know. And it was funny. I would go and do presentation. I always tell people, we don't carry people out. We drag them. It's easier and it's better for the patient. And people chuckle, but like, it's true. We just, you know, it just doesn't work out for Hollywood. So went into community relations, really enjoyed that. You know, was doing more and more around medicine. I realized that I wanted to be an officer because I wanted my own crew, because I wanted to go to block parties. I wanted to go to community events. Like I liked doing that kind of stuff. Funny story. There's a video on YouTube somewhere of me and my partner doing like the cha-cha slide and bunker gear at a block party.
Oh, guess what I'm going to find? Hang tight.
Because I was there when the camera phones came out. I'm like, this is what this should be. Like, I love this because having this level of personal relations comes before somebody taking medical advice from you.
So what you mean is you actually asked them to turn on the camera because you were about to bust a move. let's just be real about what happened here, and not, you know, not the sanitized version. Got it.
You know, I wish that was a story. You know, to be 100% truth, I was with this. I think his name was Alan, and Alan is like your super stereotypical white guy. Like, you know, he's like, hey Chief, you're like, I'm not dancing. I got no rhythm. And one of the neighborhood ladies like, nah, sweetie, you dancing today. So she grabs Alan and starts dancing with Alan, and, you know, like the music turns up.
Outstanding.
Her grabs her camera phone. Alan's like, what do I do? I'm like, dance, man. Like, you know, we good. You know, like, you know, this is what this should be like, you know.
Did he stay in the safe zone?
Yep, he did for like the first like 4 or 5 beats. And then, like, you know, basically it was like he was trying harder to not engage. And it's like, dude, just go with it, man. Like, you know, we like, granted, like you're on a predominantly I think it was like all African American block. Like, you're around a bunch of black men, and it's cool. Like, take this opportunity.
You're trying
to loosen up, right? Like, you know, it's and I'll be honest, it's the same as me at 14 at a bar mitzvah. You know, like I had that exact.
You did the electric slide, huh?
Right. You know, in inverse. You know, you know, and, you know, as you're singing Hava Nagila, and, you know, when people are kind of doing the thing, like because I went to a predominantly white, predominantly Jewish school, I was already that kid, and I was used to it. So it's like, once again, like, why not turn the tables? Like, sure. I get it. You're at a black picnic, like, go with it, man. Like, we good, you know. And I'm sure there's research around it somewhere in the sociological sciences, but I mean, just the feeling of the odd person out of being welcomed into a community, and then 2, also when a community feels it's appropriate to welcome an outsider in.
Absolutely.
You know, both parties have to take advantage of that opportunity, and that window is so small.
Yep.
But
you can earn it.
Yeah, the outputs are huge, and I feel that especially as we grow older, we shift in the wrong directions. Kids have no qualms. They will, they are honest. They will play with you. If they don't like how you're playing, they tell you, they switch the game. They have their own languages. And as we grow, we lose a lot of that.
Yep.
And I'll be honest, one of the things that somebody said to me the other day, it was just maybe like 3 or 4 days ago, I never really thought about it. I have a buddy of mine who's a fireman. He said, you know what, Josh, that's your superpower. He's like, there are so few situations where, you are visibly uncomfortable. So I'm like, I'm uncomfortable all the time. I've just gotten used to it, and not, I'm not going to say like I'm always me, because that's not always necessarily a purpose. Sometimes it's great to be a student and be uncomfortable. But I realize that so many different situations can offer me something to learn, and I'm willing almost always to take advantage of that learning opportunity, regardless of where I am on the planet.
Given the political backdrop of Black Lives Matter, for example, and you're in a part of the country that kind of flamed up not long, a couple weeks ago for some very good reason. Do you guys wear a shield on your uniform?
We do, yeah.
So, the fascinating and thin line and delicate line EMS in particular gets to be able to go into the home, right? We talk about how, as opposed to cops, fire and EMS are invited into the home, right? And I remember the first time, and it was from a rural service not far from here in California, where the chief and particularly his community engagement team wore polo shirts, and I remember asking him why, because look, he's a white shirt, right? He's got the bugles and the whole deal, and he explained to me that the shield gets misconstrued. So even if you're wearing the black uniform, not the blue uniform, etc., or the white shirt, not the dark shirt, it's the shield, right? It's the glint that stands out. And to the community that feels marginalized or concerned about why you're here, even though you're there to help, you're not there to enforce. You have no enforcement role. You have a unique perspective, I think, given the backdrop, given the geography, given your own experience of understanding how even in that community, they may know you, but once you put on colors, how that relationship changes, and if they see the shield before they see the person, what that does. And I don't think that's something we should leave to the side. That's a very delicate and important perspective I think you have. So
right. Well, and not to totally shift gears, but I mean, what's interesting for us is that we have the option. So like for community relations assignments, if we're at a block party, we should be in a button-up shirt with a shield on. If we're on just a run, a lot of times it's a polo or a t-shirt.
Okay.
And
how do you choose and why? What's the nature of the selection?
So polo t-shirt is kind of just whatever you're in. If it's the middle of the night, you're in a t-shirt, you're just going to throw in the t-shirt, maybe the bunker band. A lot of our officers, do and really should be wearing the polo shirt, because it once again has that rank, embroidered on it. Okay. And then part of our department rules is that basically if you're at a public event, you should be dressed up. Sure. And your dressed up is, your button-up shirt with the shield on it. And then it's going to have the Maltese cross on one of the shoulders. And once again, kind of going back to, kind of the innocence and the brilliance of children will 100% tell you that. If a child mistakes you for a cop, or they said, hey, you know what, are you a cop? You look like a cop, so on and so forth. That's what you come off at in the discussion. Like, take that as true. They are, unless you have a great cultural confidant, which I have some of those too. Children are my ultimate litmus test, and I, almost universally, will defer to them. If a kid understands it, I'm good. If I can teach it to a kid, I'm good. Which is, kind of when I got into recruiting, which is kind of part of the origin story too. Yeah. I think I was unique in that a lot of times I always defaulted to my target populations who could be the most honest with me. Okay. And a lot of my wisdom I got from either adolescents or children because they were so brutally honest. And realizing that when it comes to, to things that are, defaulted or are biases, they're still willing to share those. Whereas a lot of adults, they kind of tell you what they want you to hear, what they think is appropriate. Younger kids are like, nah, like you look funny. Like, it's like your colors don't match, and you just take it for what it is. Like, it just is what it is. So back to the kind of origin story. Became a lieutenant, became a captain. Realized that I was a horrible writer.
I don't think I believe it, by the way. I've read your writing. Even in emails, you're more proper than most. So what was your barometer there?
Believe you me, it was a lot worse. I actually remember I wrote a draft recruiting plan and pitched it to our school district, and I sent it off.
I don't know if that qualifies as like fascinating writing to anybody. I can't write technical manuals. All right.
Right. Well, and it was meant to be engaging. It was meant to be a persuasive piece.
Okay.
And once again, if I'm presenting to educators, I want to be able to play on that playing field, which is kind of one of the things that I've always been conscious about. Is I try to be a professional polyglot.
Okay.
I try to
read all the word, by the way, right there. Polyglot. You win Scrabble today.
But I try to really understand the grammar of my target audience professionally, wherever that exists. I mean, and even working with adolescents, like there is an adolescent grammar. There's social media grammar that's appropriate to use in those spheres of existence. And I try to get into that and write or express myself from the point of view that's going to be most effective for my target audience.
You just talked about you work in a hyper segregated environment. I did my undergrad and first grad degree in Boston, so another hyper segregated city. You talk to children, you bend your language, right? You mentioned being a person of color in various communities, right? And clearly you cross those lines, which is an art, right? It's an art and it's a science and it's a cultural sensitivity. Explain to me how you bend so far, right? You're not going to use polyglot with kids, clearly. You speak like a highly educated person.
Okay.
We'll get you right, because I don't think education and intelligence are the same. That's the wrong association.
Neither do I.
But if you speak like somebody who was educated at LSE, there are going to be people who can't relate to you or refuse to relate to you for one reason or another. How do you do that where you are, on the one hand, modifying your diction and the word choices that you have, where you don't sound inauthentic, but at the same time, you come off as authoritative? Explain to me how you bend that way, how you maintain your authentic self, how you can write, how you can then wear the raiment. There's another, that's a $2.50 word. So, but wear the raiment of all of these different communities that you're in.
So I would love to say I learned it. I'll be honest, I was kind of pushed into it as a child. So, I grew up in the city proper, and, my parents were divorced, so we were kind of split between two all or mostly Black communities in Milwaukee. However, for schooling, I was bused to the suburbs, and I went to, predominantly white schools from K4 all the way up through high school.
Okay.
So I was educated and really developed as a child of two worlds. So I had friends at school who were, unbelievably wealthy, or, who had these really different social situations and really ran that whole social economic gambit. And that was my normal for school. I didn't know any different. And then at home, my neighborhood friends were like normal neighborhood friends to me, and that went from, from housing projects to like our middle class neighborhood. My
Did you
dad
speak differently with them?
Not as, I remember being teased as a kid for like sounding white or like talking proper.
That's kind of what I mean. Without phrasing it that way, I'm glad you did.
No, it's a reality. It's kind of things like, I know what happens, why hide it? And I'll be honest, it's something that even when I speak, at schools or I'm in groups now, it's like, I know kids say that. I know they say it to other kids. And it's kind of one of the things I use to level out the room. And I mean, like, kind of like social dynamically level out, especially in high school classrooms. Kind of like, when I used to teach anatomy and physiology. And, when we got to like reproduction, I kind of started the class and said, okay, penis, 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 vagina, vagina, vagina,
Nice.
and all the kids kind of chuckle. And it's like, okay, now let's get into it. Like they're not bad words. We're going to use them. I want you to use the proper terminology, understanding that you've probably never had that experience before. And the other end of it is, I don't want the kids to be afraid of mispronouncing words.
Mm-hmm.
And, if you're going to use a 7-syllable medical word, you're going to screw it up. And that's okay. So it's something that I've always been conscious that those kids exist in every classroom. And it's important for me to level that back out because I was that kid and nobody leveled it out for me. My teachers thought it was great. It's like, oh, Joshua's so well-mannered and so on and so forth. And it's like, I understand that dynamic exists for students. So coming up, that was just the way I was. It was, if I wanted to fit in school and get invited to kids' houses, like I wanted to play. I was an only child. So I had to understand how those social dynamics worked. When I got invited to like bar and bat mitzvahs, like that was a different, like dressing up for like a 13-year-old party is a different thing, Then I would start to do like semi-formal events as like a early adolescent, either with my dad or I was like in a bowling league. We had like a dress-up dinner. So it was like, okay,
we're just gonna let that simmer.
So I bowled probably for 6 or 7 years as a kid. But again, we were like in a semi-formal league. Like you had to wear slacks and a polo shirt.
Okay.
You went to a couple of formal dinners, and it's like, why are there 2 forks? How do the forks work? So all these things, and it was like I wanted to do them all. I wanted to be decent at them all so I could have fun. So, for me as a kid, because I wasn't always in the same situation, and I couldn't always be in the same situation, and because I was the only child, my only way to play was going to be with other people.
Yep.
So I had to be astute and quickly learn those rules to play in those different environments. Because
you're a bit of a chameleon.
I wear many masks.
Okay.
So, and it's funny, even my wife, she's like, I don't know, I think that is me.
Mm-hmm.
The Joshua Parish really is a chameleon because I also love those new experiences. Like nothing makes me happier than to go to like a part of the world that I don't know, get up in the morning, go for a run, stop for a coffee or a pastry or whatever is appropriate in that part of the planet, and to figure it out and to screw it up, maybe learn 20 words, and some of those 20 words are, I'm sorry, I'm really crappy at your language, but
nice.
And I'll be honest, what I find is that people are really forgiving and enthusiastic when you just try. Especially as an American, because because that it's just out there in the planet that we just aren't into it.
Yep.
And I'm just not that guy. I'm like, hey, yeah, I will sit there and struggle with you to say hello in any language that you're willing to teach me.
Good for you.
And I will, and I will happily buy you a beer while we sit here and do it.
Agreed. So tell me, speaking of pastries or crumpets and scones, or I would imagine, and again, as a black firefighter from Milwaukee, and then you go to London,
mm-hmm.
There's got to be some odd man out syndrome somewhere along the way. And along at least one of those dimensions, if not something else. I mean, how many other folks sitting in the room with you are A, from Milwaukee, B, a firefighter? I mean, color, London is a diverse metropolis, right? It represents the world. So I don't think that's really an issue. But when you put the three together, you had to be somewhat unique in this setting. And talk to me about that. So, and how you like bring your authentic self to that conversation and say, I have a perspective that you don't. That is my super.
So, kind of getting back to the origin story, yeah. I think one of the things I really brought to my education was my lack of formal education.
Okay.
I wasn't, by the time that I started reading the research, I wasn't biased by a bunch of PhDs telling me that this was the law and having written a bunch of documents explaining that this was the law.
Okay.
I had been in people's living rooms, figuring it out on my own, identifying what did and didn't work. And then when I got to college, when I did my, I took that English class rolled that out into an associate's degree. I was going to be a nurse. My wife said, absolutely not. Roll that into a public health degree. And I remember reading this public health research and going, you people believe this stuff?
Nice.
Like,
Nice.
you know, I remember reading it and going, there's a whole lot of like formal teaching in here that's theoretical that I can tell that you did with kids on a college campus. That doesn't work in the real world. Your educational time with that given patient is minutes, literally minutes. Like, I remember thinking to myself, have these people ever been to a doctor's appointment? Like, it's 15 minutes of time in a room, of which 5 the person with dual PhDs asks you a bunch of questions. You reply yes, no. You tell a quick story. They scribble something on a piece of paper, and then off you go.
Yep.
Like, that's a medical encounter.
Yep.
So,
and now they're recording it in a little handset. Right.
So, reading this research talking about, how do we educate diabetics? It's like, you don't. None of you can. And even if you do, none of your metrics talk about how well they remember it, because you can't measure that it's really hard to measure in the real world. And, it's really hard to even figure out how to measure, which makes a crappy research project, which makes a crappy grant application. So what I found in, a lot of especially the US based education, was that it was really centered around research that was easy to do and measure and get published, which bothered the mess out of me.
Yeah. That
irked me. And I discovered.
Have you been in the EMS business for a minute?
I had. I mean, but I had gone to school. I became a paramedic, and then I learned what worked from a communication and education standpoint, and really from an influence standpoint. I learned that in people's living rooms. I learned talking old women into taking their furosemide. I learned that in somebody's living room about what works and what doesn't. And, she wasn't that woman, that older patient. She won't do it for her. She'll do it for the family. She'll do it for her grandkids. She'll do it to remove worry from the situation. But a lot of, especially among older adults, a lot of that priority for self-care isn't revolved around producing a great outcome for myself. And in studying behavioral, and really just reading in behavioral economics first, like I read Freakonomics, fell in love. I applied to LSE because I was looking for programs for somebody else. I'm like, LSE, that's interesting. Like, I'll give it a shot. I'll be honest, I didn't know anything about London School of Economics.
Were you applying? You were applying, like researching on behalf of somebody else?
Yep, I had met a banker through a school I was working with, and we were talking about behavioral economics and all the work they had done.
Yeah.
In, like preferencing and framing for savings.
Okay.
And she was, yeah, I would love to go back to school. I'm like, let's see if we can find like some executive programs and we're like in my office. I'm like, London School of Economics. Sounds interesting. And I applied to that, and I applied to MPH programs.
Okay.
And in my application letter, that's where I wrote about, I said, hey, this body of research is misguided because a lot of what we do in medicine isn't based in patients wanting to produce positive clinical outcomes for themselves.
Mm-hmm.
We think, we have this foundational economic theory of perfect information, which is absolutely false, and people wanting great outcomes for themselves, which the research doesn't bear. But behavioral science understands and acknowledges that and says, hey, social capital is important, temporal pricing is important, setting defaults is important, and you can use these basic concepts to produce outcomes that your patient or your target audience would have wanted, with still giving them the choice to opt out if it's what they so choose, but you can make the world or a situation better using these concepts.
Okay.
So when I got to London, and I applied and I got the letter.
That was all in your application letter, by the way?
Yep.
Like
that
your
was
essay?
an application letter. And it was about using the social capital that we had as a fire service in the community,
sure,
and leveraging that in community paramedicine, leveraging what we understood about communication for our target audience, because we aren't university educated.
Yep.
We don't have those biases built in. Most of our staff, we don't, break out 27 syllable Scrabble words. We don't use polyglot in everyday language. We go, hey, Miss Parker, like, I've been here 7 times, and we'll make a joke. We'll say, hey, I know you're sick of seeing my ugly mug, and I know your grandkids are sick of us waking them up in the middle of the night. So let's talk about your diabetes medication.
Mm-hmm.
And then for those of us that are engaged in community paramedicine, and it becomes, how do we address all the other social determinants that exist
Mm-hmm.
to get your blood sugar stable?
Mm-hmm.
And, how do we incorporate Meals on Wheels or Housing First, or identify your polypharmacy issues to address your foundational health issue,
Mm-hmm.
understanding that most of our patients, like the literature is clear, our patients are not numerate, because most Americans aren't. Our patients are not medically literate because most people aren't. I mean, a lot of physicians aren't medically literate.
Oh, yeah.
And, especially because we're in the United States, most people also understand their insurance. Like, physicians don't understand how they get paid,
Mm-hmm.
which isn't really a surprise.
Oh, EMS doesn't understand how it gets paid.
No. So why are all of our assumptions based in these understandings that are demonstrably false? So when I got to London, I'm like, that was my application letter. I was like, hey, you know what? Like, especially in American healthcare, like, we've screwed this up. We are an industry who has a ton of social capital, and we've used that social capital to say, stop, drop, and roll, put up a smoke detector.
Right.
Use that exact same social capital to say, hydrochlorothiazide is like the cheapest medicine in the world, and it can keep you from having a heart attack.
Yep.
And if we're here 3 times in a year, and you're getting your hydrochlorothiazide from Walgreens, why don't we just go with a pharmacy that can bubble pack it for you, say Monday, Tuesday, Thursday, 10 a.m., noon, and we'll send you a text message to remind you to take it. There's the text message is a fraction of a penny. The
Mm-hmm.
bubble wrapping is free. Your insurance would have paid for it anyway. They would prefer to keep you out of the hospital and keep you, out of the ambulance.
Mm-hmm.
I don't want you in the ambulance, especially at 3 o'clock in the morning. Like, everybody wins
Mm-hmm.
if one person steps back and says, hey, let's just do this better, and let's do it better times 5,000 times a year.
I have an MBA. You have a degree from LSE. So we are not the average person in our industry anyway.
Mm-hmm.
But community paramedicine is a fraught topic politically, although the politics I think are overblown. Most people don't understand the numbers, need to understand the numbers. And if we understood the numbers and people were willing to understand where the math mistakes have been propagated, they would realize that this not only has a future, but is possibly the future for this industry. And you are busting, you are taking a wrecking ball to the ivory tower, which I love. I mean, not for nothing, but like, there is something so interesting about, like, I piss people off by my very existence, and it's taken me a decade to be cool with that. For the second industry that I've been in, first time I did it was in media, and I'll tell you, man, when the then editor of Newsweek magazine, Mark Whitaker, once called me the industry gadfly. He became the head of news, I believe, at CNN or NBC, and he called me the industry gadfly. And I remember thinking, oh my God, Mark Whitaker knows my name. Like, I don't care what you want to call me, man. You have any sense of who I am good. And the interesting thing is you have paid your dues in a way that, for example, I did not. When I came into this industry, and for many years in the technology part of mobile medicine, my business partner and I kind of hid behind this idea that our company is the only one in our industry founded by 2 non-clinician MBAs. And there were and still are people who would look at me like, what the hell do you know? You've never run the truck. Well, first of all, I spent a lot of time on the truck, but besides that, as the industry becomes data driven, there was a place for us, right? And so that became, went from a handicap to a benefit to be able to say, I can't tell you how to stick a tube down somebody's throat, but I can tell you what it's worth. But you have paid your dues, right? So you've been on the truck, you've come up, and I think it's so interesting, going back to where you started this conversation, talking about having been educated in a very detailed fashion on a science of paramedicine and the art of paramedicine. And I have many times said, and I've never been joking about it, I don't understand why people get afraid of EPCRs and computers. Like, if you can bring some poor soul back to life and stick a tube down their throat, pull them out of the back of a car, do all the things that you do, figure out how to keep them from not only lift them off the ground, but help them not fall again, you can figure out a charting system. Like, this is so much more complicated. There is an obsession in our industry with degrees. And if one of them doesn't have an M in it, you've got a problem. If the M it doesn't actually stand for medical, you've got a bigger problem. There is this phrase that the fire service is 150 years of tradition uninterrupted by progress, and it's complete nonsense. Like, I hate this, and this idea. And I know I'm on a bit of a soapbox, but there is so much brilliance in this industry, and it comes from people of all patch colors and all affiliations, and private services, public services, the most amazing innovations. There is this, and there's this obsession with being a big city. There is the obsession with having a medical degree, and here comes you saying, I cross all these boundaries. I go to LSE. I speak in proper and high language, and I work inside a service that believes if you want to break the technology, give it to a firefighter. Like, I don't get it. The worst critics of the industry is the industry itself. I have gone to conferences where I went to the Society of Trauma Nurses, and I will never forget this. I was one of 3 people in the entire conference representing mobile medicine. Okay. And I'm sitting in these conference presentations where trauma nurses from the University of Louisville and from University of Kentucky, happened to be in Kentucky. So, like, from all of these places are saying, how do we do our jobs if we don't have pre-hospital data? Like, we have to know what's coming in the door, right? If we don't have context on what you're dealing with, everything you just said, by the way, right? You've got minutes, but in those minutes, you have captured clinical knowledge, context, what this person has put in their body, what they didn't put in their body, right? What their background is, all of this stuff, and you get 30 seconds to hand it off. And you think that the receiver doesn't care? Without that information, they can't do their jobs. Why does our industry not recognize so much of what you've just said, which is our research is porous. We have huge companies who actually advertise millions of records under coverage that are a sample size of 1, because they're all being generated by a single data set, right? So the number of biases that go into the self-selection of who chose to go to this product and not is a total confounding factor, and yet never gets confided, gets thrown into the research disclosures. Or if they do, it's a footnote, and yet they still publish the research. Now, I'll get off my soapbox. Reconcile that for me, because you have the research background and the clinical background, and you're on the ground with the folks who should be reading this but don't know where to look, and think that nobody cares about the work they're doing, and you know otherwise. So you got like 4 major threads there.
So what's interesting is that I was actually thinking about that the other day, and it's something that when I first so I got promoted last year to deputy chief in charge of our emergency medical service. So that was one of the first things that I came in and observed, was that it was exactly the problem that you mentioned. And I'll be honest, I've been so busy of late, I haven't had time to address it. But the primary problem is that there are feedback loops that we're culturally used to, that we're acculturated into. And they're different, once again, being kind of that back to the professional polyglot thing, we're used to different feedback loops for all different things. So when you look at paramedicine, even, us only dealing with, acute patients, we're looking for, if I do a 12 lead, I am looking for, one of 15, 20-ish rhythms that will then give me my next thing to do. If I'm looking at a hypertensive patient in paramedicine, that hypertensive patient better be so hypertensive they may stroke out right now. 130, 140, we don't consider to be hypertensive, because that feedback loop for that chronic condition to produce a poor outcome is too long for our scope.
Okay.
So when you look at when do we get feedback and how does that feedback inform what we feel good about and what we can operationalize, we haven't developed a feedback loop that's short enough for EMS to operationalize research until we started getting really, the ability to incorporate dashboards or to incorporate, really some really robust analytics in real time. So, being able to process through, being able to process different run types through First Watch has helped me immensely to say, okay, I understand how your system, and we had First Watch for years.
Mm-hmm.
And I said, okay, I understand how your system works. So I can watch anything. Like, yeah, you can watch anything. Like, okay, so let's play with this concept a while. Let's take, this call type category, make this suffix a wild card. Now it's grabbing 3 or 4 different call types and tell me what the average for that is. And let's make that call type overdose. And so, okay, now that doesn't match up with our opioid overdoses. Kind of getting into AODA, there's something missing. So what we've always used to say, hey, our overdoses should be in this bucket, the bucket isn't full enough. Where else are these runs hiding?
Mm-hmm.
Because now I know we've done it wrong all these years.
Okay.
And then ultimately, how do I operationalize that insight into my field companies? So, kind of using that understanding of when I became once again, I was educated, in people's living rooms. So I know that firefighters want something that they could use on that shift.
Sure.
So the question then becomes, how do you change something that we're going to research for a year and then crunch data for a year? How do I shrink that feedback loop to something that's manageable enough to give it to a field supervisor, a lieutenant, or a captain to say, hey, here's what you did Q1 of this year. I want you to do this Q2, and Q3, I'll tell you exactly what it looks like for your patient subset.
This podcast that I do, so the name of it is Sacred Cows and Data Cubes, right?
Mm-hmm.
You are slaying sacred cows as you go. You are turning them into steaks and then feeding them to people. How? Go ahead. I want to know how the industry is allowing you to do that, and in fact promoting you. Like, you have bugles now, right? So there is a secret to something you're doing. You are not to make. I don't think it's too subtle a phrase to say you're doing exactly what we should be doing, but you are bucking tradition in an industry that prides itself on saying, well, on the one hand, we want to be progressive. On the other hand, we're uninterrupted by progress. And so you are the demonstration that somebody can, in fact, do that and not only succeed, but thrive. And if that becomes part of your legacy, which is part of my job here, is to call out the people who would not stand up and cheer for themselves. That's my avocation. But it's also a demonstration that it's possible. So tell me how you're being allowed to do that. And is that people saying, well, you know what, he's the smartest guy in the room, so we're going to let him speak. But at the same time, he's breaking heads. And so, like, there are people whose sensitivities are getting ruffled, and clearly you're managing to navigate that. So what is this? Yeah, what's the secret there?
So one, I'm definitely not always successful. I've definitely screwed that up a lot. And I feel that, kind of going back to the ivory tower of research, one of the most important research that we don't publish is what doesn't work. When I'm going into a program, when I'm researching programming, when it's recruiting or anything like this, what I want to know from people first is
Failures.
Tell me what's messed up. Like, seriously, come in, complain about 20 things to me, and let me know what you hate. And let me know why you hate those things, because that then becomes the capital that will get you to buy into the solution.
Yep. So
a lot of times what we do is we, in research or from academia, we've identified problems that have manifested through, through quantitative items, and a lot of times you see that with some of our system research. We may look at like the effect of like some obscure drug on like some random heart defect. Not that it's not bad, but it's like, do our clinicians, are they in love with that concept? And if the answer is no, then your dedication to that work is going to be really, really minimal. Mm-hmm. And I don't think that's unfair. If our clinicians are in love with kids, and we're seeing a lot of pediatric trauma, then what they're going to be in love with is what reduces the mortality rate among that pediatric population. Right. And, even from our medical directors are clinicians. They're not behavioralists. And what a lot of times we skip over in those clinical occupations is the fact that a lot of our health issues are behavior based. We don't have, all of our patients aren't, they aren't hypertensive because they were born that way. We don't have this huge preponderance of genetic anomalies. We have people who do things that contribute to poor medical outcomes,
Sure.
both, clinically and amongst our clinicians, even from a documentation or operation standpoint. Do we believe or do something that's contributing to a poor patient outcome? And then the question becomes, why are we doing it? It's not just stop, because to be quite honest, we could be doing it for a great reason.
Yeah.
We may just need to redirect that effort, to redirect that desire.
Sure.
I think we saw that a lot in COVID. There were clinicians across the country who believed, or maybe they were really justified in saying, hey, you know what, like, you're not critically ill. The best place for you right now is not a ED.
Right.
And that, may or may not have been true. Some of the mortality data that's coming out from the chronic conditions identified that, the people who are at risk of getting sick weren't statistically at a huge risk of necessarily dying had they had engaged a healthcare system. So, knowing that behavior is at the forefront of everything, or most things that we do in medicine, is where I come from first. So if I can fix a popular complaint, I'm going to get better buy-in, as opposed to saying this is the right thing to do. And that once again, being that polyglot, that conversation starts with who are my stakeholders and what do they really want. And even when promoting the exact same solution, the manner in which I describe the importance of that solution may be different for 5 different stakeholder groups, which is perfectly fair. And for me to not acknowledge that difference, and I know it, I feel that I do them all a disservice by not saying, hey, you know what, you're a politician. Do I know what the outlay is, for the morbidity rates for this particular condition amongst your constituents? In a city like mine, it's going to be, Puerto Rican Spanish, which is a little bit different from Mexican Spanish. It's going to be some Somali. It's going to be a little bit of Hmong. It's going to be, English in a bunch of different variations. For the neighborhood I live in, I actually live in our Orthodox Jewish congregation. So it's going to be understanding that, from sundown on Friday to sundown on Saturday, that message has to change because of the cultural context of your community.
You mentioned New Orleans, Pidgin and Creole and Ebonics, and those sort of hybrid languages that come out of a cultural context. You mentioned the Jewish community. Yiddish is a hugely important language to be able to understand if you're going to work with an Orthodox Jewish community. And so to understand those,
and mind you, I do not speak Yiddish.
Neither do most people. Look, that came up in New York during these recent social uprisings as a huge problem. Like when the Rebbe dies, the people will come out in force, and the mayor of New York had to deal with the fact that you are not going to keep the Hasidic community in their homes or wearing masks. They will come together to celebrate their rabbi. And
Right.
So, understanding how to deal with that, do we need to hire people with humanities education?
So it's interesting
with STEM or biology. You can teach the medicine.
So for the past decade, a lot of my work has really been in recruiting and diversity. And I worked a lot with Matt Hines-Aldrich, who I'm sure, that the name has come up, and one of the things that, we were really big proponents of is building your own. So I think that, especially looking at the business aspect of it, your choices are build or buy, and if you buy, you come up quicker, but you learn more by building, and you can develop more efficiencies if you take the time and you invest in building.
Yep.
My preference actually, I think that there's a big system answer and a small system answer. If you're in a smaller system, I would say the preference is going to be buy, because your ROI for that individual skills, you have to realize those a lot quicker, understanding that you can't hire 40 people every year. Right. In a bigger system, I think the preference is build, because once again, you don't have those biases that are developed with really what is like a homogenous educational system.
Okay.
You know, so in that respect, this is one of the times when like I like the armed forces model,
Okay.
where you have a general intake pool, and you start to say, okay, where are people's talents and skills, and then how do I invest to build those out into both what we identify that we need and to fill gaps that I know exist, but I don't know why I need that gap filled yet.
Yeah.
So it becomes the far as like, hey, you have somebody who you hire somebody, or conversely, one, you're deliberate about seeking out the applicant who is not like your current employee pool.
Right.
So you find, you go to the mosque to find the woman who's fluent in Farsi and Pashto and plays basketball. Like, you find her and you say, hey, you know what? Like, you don't say, do you want to become a firefighter or EMT? You start by asking them, what do you want in a job? And then you identify, can your job fill those wants for her
Mm-hmm.
in enough of a way that she wants to do the job? For a bigger institution, it becomes, how much are you investing in creating a culture that can be adapted for your future that you can't plan for? And I think that, for me, I had chiefs who were supportive of that, who said, oh yeah, like, you can take time off, go to school, well, you can make trades. And they were encouraging in building me into a tool that nobody knew that we would need to. Nobody could have imagined that, that a HIE would have existed 20 years ago when I went to paramedic school. I think that's really important. As I say, you recruit people who are going to identify those blind spots, and the more odd they are, the better.
Mm-hmm.
A lot of times, especially in big departments, we say that those people are hiding behind a desk.
Sure.
But I think it's quite the contrary. It's that, their skill set may not be 100% for the field, and I'm good with that. If a good firefighter does not a good lieutenant make. You're going to hit the point where it's like you fall into your niche and it's perfect for you, either because you're great at it, or a lot of times, honestly, you may be doing a job that nobody else wants to do. I'm cursed with being good at paperwork. I have the attention span to be able to read through a 60-page document and highlight and retain like 2% of the information that's important to our service, to go, oh, like, this was written for, this was written like literally for NASA, but like these 4 sentences apply, and we're going to bring these 4 sentences into our service. And I think that for our traditional practices, you see that in special operations and technical rescue.
Okay.
You have, where we're eager to onboard construction workers and welders and carpenters and plumbers, and even like, now mechanical engineers and structural engineers and people who were sappers and in the Army Corps of Engineers. Like, we're grabbing those people because we're saying, hey, like, hands dirty, that you can do this. We did it in hazmat. We were saying, hey, if you're a chemist or a biologist, like, if you're a nerd who doesn't want to work in the office, like, hazmat is for you. And we're starting to do it with medicine, where we're saying, hey, and this is something that we were adamant about, going to a high school and saying, you want to do medicine? Do you want to practice on patients at a high level? Do you want to do it in 2 years? Well, then I got the job for you,
Sure.
And it became, our selling pitch in high schools really became, if you want to get into medicine, but you don't necessarily want to sit in a college for 2 or 4 years and get a ADN or a BSN, I can have you practicing on real patients by your 13th month of employment, and I'll pay you while you do it.
What does it say about your candidate if the candidate loves the idea of practicing medicine, but gravitates to the pitch that you get there in 2 years? That sounds like, hey man, shortcut sounds great to me. I don't know that that's really, that same person is also going to be protocol driven. That's a little bit of a mixed blessing there.
So what's interesting is that I like it, and here's why I think it has value, because that person, I was that person, and I think that there's a lot more people like that, who you put them in a traditional college environment and you start them out with a semester of chemistry and a semester of biology and a semester of English 2, and they haven't started talking about medicine yet. You know, when you look at our college dropout rate and our college incompletion rate, I think a lot of that comes from, I never got to do what I wanted to come here and do.
Yeah.
Now, conversely, if you're saying, I want to do patient care and I can give you entry-level EMT basic in a semester, and I can give you CPR, and I can actually introduce you to patients, and then I can that next semester start to give you electrophysiology and teach you how to read a 12 lead, and then give you some patients to do them on. We basically inverted that practice to where you learn a little, you do a little. You learn a little, you do a little.
But are you also rewarding a culture of instant gratification?
Yes, 100%.
Is that bad? Maybe not. I don't know what it is.
But, and you know, I'll be honest, and I'm so emphatic about saying yes because that's where we are.
Mm-hmm.
You know, I don't really get to. It's kind of one of those where I can pick outcome or I can pick process, but I can't pick both. And ultimately, knowing that I have so many young people who are fueled by that, who if I don't grab them now, I won't be able to grab them in 7 years. You know, in 7 years, once again, they will have had a mortgage to pay, a car note to pay, and so on and so forth. And if I wanted them, and I wanted them to be a behavioralist, I should have grabbed them early and invested in them. In my career, I've gotten promoted every few years because we've always had different things that I could, you know, specialize in. In a small system, that's not an option. So it makes more sense to hire your asset. In a bigger system, you can go hazmat, 4 years, tech rescue, 4 years, paramedic on a box, 4 years, management level, 4 years, research, 2 years. And you have 12 years of a career.
You have a career. Yeah, that's right.
You know, and you haven't left, and you do an educational semester in there 3 or 4 times. You do a sabbatical or something like that. You do a part-time degree program. You say, hey, you know what? I know that we need this. You go take 4 classes. I'll pay for half or all of your tuition. You come back and share your knowledge, and they go, okay. You know,
like you just say, you're grooming your Swiss Army knives.
Yep. You. I like to call them Gerber tools. Because it sounds cool and we use Gerber tools.
Nice.
But yeah, it's like, you know, for 400 years of fire service has been perpetuated by samurai swords. You know, they're exceptionally sharp. They're cool. They do one thing.
Yeah.
And now it's like we have the whole Gerber tool factory.
Yeah.
And I'm recruiting shells and saying, hey, yeah, you know, pincher, plier, we're going to pick the rest of the tools as we go. And because we're recruiting people with the space in that tool, you know, we're basically future-proofing ourselves.